let's begin. It is working. It's really loud. Hi everybody, my name's Paul. I'm the dietitian from Charlie's, and I'm just going to talk to you about nutrition in respiratory patients. Jean, do you want to introduce me? What I did want to say is that I apologise that I did get a request to send the presentation through about 2 weeks before, and when I went to uni I learned, after a couple of years I gradually became a really good student and learned to do things at the last minute. So that's my apologies for not sending the presentation through, which is why you don't have a handout. It's not Jan's fault or CFWA, it's mine, it's all my fault. So I wrote it fresh, so it's like fresh and exciting. The goal of this afternoon for me is that no one would fall asleep. Yeah, because I know it's you know, the end of the day, and you've just eaten and drunk, and now you're going to sit down and we're going to try not to cause you to fall asleep. So what's the diet for diabetes? You would probably all automatically think of some concepts. And so what would the diet be for heart disease? You would all automatically think of something, right? And what should someone have who's got renal failure? You would automatically recognise and identify. And what would be the diet for, you know, stoma, or someone with... So you'd think of some things. So what is the diet for respiratory patients? Sorry? Okay, all right. So that's interesting. So I would have thought, and that's a reasonable answer, and you're probably not wrong, but I would have thought that, and my point would be that there's probably no real recognised diet for respiratory disease or respiratory patients. And to me, I also, being the respiratory dietitian, I'm like, hey, what about me? You know, what about me? So I think it's under-recognised, and that would be my first point. Would be that nutrition in respiratory disease is paramount, and it's really important. So nutrition for everybody is important, but when you have organ failure and when you have a chronic disease, that is a disease that is most likely something that progresses, then nutrition becomes even more important. So the symptoms of someone with respiratory disease almost always associate with reducing intake, or they are a barrier to adequate intake. So all of the essential nutrients that our bodies need to be healthy and function are in food. So if you can eat a wide variety of food, you can get all of the essential nutrients that our body needs. And so when you can't eat enough food, then you're not, very likely not going to be able to get enough nutrients. So if someone presented to ED with cough and loss of appetite and, you know, early satiety and weight loss and shortness of breath and fatigue, it's probably a respiratory patient, but they've also probably not been eating well for quite a few days. So that's the picture of a general respiratory patient, right? So assessing someone's nutritional status is a really important part of admission. And it's something that can be overlooked, and it's something that's, like the first thought, the first point is that it's something that it's under-recognised and underappreciated, but really important. So malnutrition, by a classic definition from, you know, the World Health Organization or whatever, could be an imbalance of nutrition leading to a negative effect on body tissue. So malnutrition, by definition, can be obesity, or classic undernutrition. And today we're probably really going to be talking a lot about undernutrition, which was the reason why, with your experience, people with respiratory disease need more calories. I'm really happy for people to call out, because if that helps you stay awake, I'll achieve my goals, and you'll get more out of it. So I don't know what sort of a mix we've got here. Dietitians, classically, a lot of them are passive learners, so they can just sit there and absorb. I wasn't one of those students. I actually like to interact and talk and ask questions and say things back, clarify things. So if you're like that today, you and me will get on well, and I'm happy to answer questions as we go along. So there are a number of obvious things that are really important in respiratory disease. So, and a classical one would be anemia. So poor or inadequate iron intake or inadequate iron absorption over time can lead to anemia, and that will lead to shortness of breath and lethargy and fatigue. Low protein, and the main body protein, the main blood protein is albumin, and that can contribute to edema, so that can be a problem. It's a real problem when it ends up in the lungs. There are other factors that come into it that can prevent pulmonary edema, and thank goodness that the body has those protective mechanisms in place. So it's not all about inadequate protein intake, but that would be a real problem. Pulmonary surfactant, going back to your anatomy that you learned when you went to uni, is comprised of protein and phospholipids, and that enables breathing. Breathing's a real problem with low pulmonary surfactant. By the way, just give me a bit of an idea, how many people here are nurses? Yeah, and how many are not? And physio? And any other? Okay, so physio and nurses, all right. Is a midwife a nurse? Specialist. Okay. Lung connective tissue. The whole supporting network of the lungs is composed of collagen, and inadequate vitamin C intake can be a real problem. Collagen is something that's turned over continuously, as is a lot of our body tissue, our skin, for example. And so vitamin C, and these are just examples of the importance of nutrition in our lungs and our health. So malnutrition compromises a number of body functions, immune function, increase the risk of infection. A lot of people with end-stage diseases will die of pneumonia. So whether it's anorexia, cancer patients can ultimately, the cause of death can often be pneumonia. So it's really important to have a good immune response. And so malnutrition obviously is going to increase someone's risk of pressure injury, falls, increase hospital stay, increase cost to the health system, and mortality. So with malnutrition, there's a correlation with body mass and respiratory muscle. So as malnutrition progresses, the patient will progressively lose respiratory muscle mass, and that's a real problem. And ultimately, who knows Karen Carpenter? Karen Carpenter died of anorexia nervosa, ultimately respiratory failure from malnutrition. So the last thing that the body, so with malnutrition, where her cause was, anorexia, but the body will lose muscle. When it loses muscle, it loses function. The body will prioritize that muscle wasting from the arms and the legs, and eventually it'll be the heart and the lungs, and she died from heart failure, from malnutrition. Okay, so that's the end of our patient. If with chronic progressive respiratory disease, if we don't identify their nutrition failure early and intervene and prevent and treat the cause and provide nutrition support. How are we going so far? So, on the other side of the scale, we have a patient with decreased intake, and we often have a patient with increased needs. So, increased work of breathing. So it's a bit of a double whammy. At the same time that they're not eating well, they're also often, I'm not sure about your patients in your setting, but at Charlie's they're often septic, so they have fever, increased work of breathing, and their protein requirements are increased, their energy requirements are increased at the same time that their energy intake is reduced. And this can be overlooked in someone who's overweight. So, we live in malnutrition is under-recognised, as well as respiratory, the importance of nutrition in respiratory disease. So, patients can be well-nourished, even overnourished, but if they're not eating well for, longer than 2 or 3 days, and if that is a progressive cycle where it's happening every year, then every few months, and then every month, they are losing weight, often as muscle mass. When they're losing muscle mass, they're losing muscle function, and that is a real problem. So, okay, we'll move on. I could get sidetracked. Inflammation. So, with infection and inflammation, there's cytokines, tumour necrosis factor, interleukin-6, and they increase the body's metabolism, increase muscle wasting by protein turnover, and that's often happening at the same time as loss of appetite, shortness of breath. So it's really difficult to coordinate a swallow when you're struggling to breathe. And coughing, you just don't feel like... Catabolism? Catabolism. Yeah, catabolic. So, if you're catabolic, you're not storing fat, you're not making muscle, you're not storing carbohydrate. So, it's the opposite of anabolic. So you would have heard of anabolic steroids, and anabolic is building up and storing muscle and storing glucose as glycogen and even storing energy as fat. So we may as well get sidetracked here, we may as well. So the body stores energy as fat because we only have enough carbohydrate stored for about 48 hours. And then the body has to, so when your intake of carbohydrate is inadequate for longer than 48 hours, you're now starving. You're now, the body converts from using carbohydrate as the predominant energy source to using fat, and we turn fat into ketones without adequate carbohydrate, and then the brain is operating at about 50% of capacity. And that's where your patient who is, they'll be confused. What are you like after 2 days of starvation and you haven't had any sugar? I'm angry, I'm irritable. I'm tired, I'm lethargic, I don't feel like walking or running or jumping around. So the body has only enough glucose for about 48 hours, and then we have to make glucose. How do we make glucose? We can't turn fat into glucose, right? So there's no biochemical pathway for that. So how do we make glucose after 48 hours of starvation? Break down what's left. Protein, excellent. So we break down protein and we convert the protein to amino acids, and we convert, well, protein gets broken down to amino acids, and the amino acids can be converted to glucose. So where does the protein come from? Where's our body's store of protein? Muscle. Yeah. So after, you know, the whole low carb diet is just insane. I should be more professional. I'm being a bit relaxed. There's no scientific evidence base to make it rational or logical. So for a start, fat burns in the flame of carbohydrate. So to burn fat efficiently, you actually need glucose intake. So the very best diet is a healthy diet with a little bit of carbohydrate and a little bit of fat and a little bit of protein. Does that make sense? Yeah, but I'm not going to sell a book with that because it's just not trendy. So I love carbs, okay. So after 2 days of not eating, we're now burning about 100 grams of muscle a day just to keep our brain functioning. And so red blood cells can only use glucose. They can't use ketones. So red blood cells only have a motor that burns glucose. So let's all not eat carbs and lose weight. Do a course online, and no, okay. Move on. All right, so with your classic respiratory patient, they're going to have shortness of breath. They're going to have coughing. They're going to have fatigue. One of the things that I think of is that how can this person prepare meals? How can they go shopping and do cooking and prepare meals? It's difficult for us to do, and we're healthy. You come home and you're tired. What about when you come home and your lung function is 50% predicted? So there's some things that upon discharge we've got to be thinking about putting in place to help them to prevent this vicious cycle of progressive respiratory decline with inadequate intake and muscle wasting and weight loss, and they're just not coping. So prednisolone increases appetite. It can cause weight gain, but the negative, the deleterious effects of prednisolone outweigh the benefits of the nutritional benefits. So if someone needs it, they need it to open up their airways, but it can be really bad for your bone health and your overall nutrition health because it increases protein turnover and increases bone turnover. So ultimately the patient goes 1 step forward and 2 steps backward. But antibiotics can affect your sense of smell. Most of our taste comes from our smell. So patients on antibiotics can lose the pleasure of eating. They'll lose their taste and their smell. We know it can cause diarrhea. It can cause nausea. So then patients often who are not eating well and not moving very well, will have constipation. They may also have diarrhea. They may have both. Loss of appetite, nausea, and dry mouth. Any questions or comments? Okay. So there's lots of theories about what nutrition could do for asthma. Unfortunately, there's not a lot of evidence when you put it all together, and there's no real strong evidence for recommendations for special nutrients in asthma. There's some thought that vitamin C and omega-3 fatty acids may have a role, but the evidence is lacking, and we probably really need more research of quality to provide. There's a misconception that milk and milk products increases mucus. Who's heard that? Everybody. So the byproduct of drinking milk, the process of digestion begins in the mouth with salivary enzymes. So salivary enzymes will begin the process of digestion in the mouth, and drinking milk will leave a film in your mouth, and a lot of people associate that with mucus. But all the studies that have been done, all the research shows that drinking milk and milk products doesn't produce mucus in your lungs. So it will produce a film in your mouth, but a little bit of water in your mouth, rinse your mouth, gargle, and problem solved. So some people can have milk protein allergy, but that's rare in adults. That's more associated with children. It's a childhood condition. Most adults, it resolves. The main problem with drinking milk would be lactose intolerance, and the symptoms would be gastrointestinal and have nothing to do with the lungs. Some patients with asthma will report that milk makes them feel tight, and if you have a patient who experiences that when they drink milk, they're probably just going to avoid it anyway, and there's not really much point in arguing with them. Any questions there? Any comments? So in asthma, people have a lot of food allergies and intolerances. They're usually fairly good at identifying those and avoiding those, but we just need to watch out for them and provide support to help them avoid that. Avoiding any food is going to limit the source of nutrients that you get from food, so it's important that they find an alternative. So if someone does avoid milk, it's good to have an alternative. So the alternative would be calcium fortified soy milk, for example, to provide the main source of calcium in the diet. The main source of calcium in the Western diet would be milk and milk products. Okay, so there you can read that faster than I can say it. Okay, COPD, emphysema and bronchitis, chronic obstructive pulmonary disease. The goal of the American Dietetic Association is that there to maintain nutritional status, a ratio of lean to adipose tissue. So people with COPD can maintain their weight, and as I've hinted, as I've been explaining the mechanism for that and led up to this, they can maintain their weight but be losing muscle, and they can be eating poorly and maintaining their weight by storing fat. So they're progressively losing muscle, and they can be rugged up, and we cannot necessarily see that they're wasting. So that's something that the ADA have recognised and implemented into their goal statement for COPD, is to help them to preserve their lean tissue. So we really want them having a diet rich in nutrients, rich in antioxidants, rich in vitamin C. A lot of people with COPD are smokers, and they'll have, that would be the main cause of COPD, would be smoking. And smokers have increased vitamin C requirements, so it would be really important that they get a diet rich in fruit and veg and lean tissue, lean protein. Pardon me. So malnutrition commonly develops in COPD, even if a patient was initially overweight. And they'll have difficulty chewing and swallowing, coordinating a swallow. It can be really difficult to chew some foods, especially with end-stage COPD. So we're looking at adjusting the texture and the types of foods that they eat to make it easier to swallow. So soups and soft foods may be on the menu initially, particularly while they're having an exacerbation. So diarrhea and constipation, I'm sure that nurses are very good at treating that. Yeah, we don't tolerate constipation, do we? Bowel not open 3 days, you're going to get it. That's what it's like at Charlie's. Right? So, one of the obvious reasons for constipation with people who are sick is inadequate intake, right? They've just not got bulk in their bowel, and so they probably need to start eating. If we can correct the underlying problems, that will really help them. Okay. Nutrient needs. So really needs to be based on an individual assessment. So whether a patient is overweight or underweight, whether they've had long-term weight loss, whether it's just short-term weight loss, whether their weight is stable. With obesity, one of the things dietitians like to do is adjust their weight to get an ideal body weight, and then aim for a target with their ideal body weight. So if someone's obese, we as dietitians are usually trying not to feed their adipose tissue, but feed their lean tissue, so feed their ideal body weight. Does that make sense? So we have a little calculation for that where we have an estimation of their adjusted ideal body weight, and when we tube feed them especially, we'll tube feed them for that, making sure that we're giving them the essential nutrients and protein for that target. Nutrient-dense foods, as I mentioned before, adjust the food texture if necessary. So some people would benefit from soft diet or even choosing soft foods. I don't know what your diet menu is like at your health facility, but at Charlie's, if you put someone on a soft diet, they get less choice. So they just get, here's the soft meal of the day. And you know, so diets can be restrictive. So dietitians, might surprise you, dietitians don't like diets, because I love lifting restrictions, and because that means that a patient is going to get more choice, they're going to get more sources of nutrients, essential nutrients, and their ultimate nutritional status is going to be better off as a result of lifting restrictions. So sometimes I like to take a person from a soft diet, put them on the normal hospital diet, and encourage them to choose soft options. And often they will. I mean, if people are really good at common sense decisions and managing these conditions, they won't order a steak, they'll order the lasagna. And if they order the steak, I would come along and have a look at that and say, how did you go? You know, and there's 80% of it left, and they spend an hour chewing a piece of steak, trying to get it to a texture to be able to swallow while they're struggling to breathe. Maybe you should choose the lasagna next time, right? Or would you like the option of a soft diet, and give them the choice. So that's a great thing to do. Sometimes doctors will, and this is where we come in. Is there any doctors here? Great, so we can talk about it. So sometimes doctors will let's be honest, often doctors will, am I being filmed? Oh. Okay. Can we delete the bad, all the politically incorrect stuff that I've said? Don't sue me. I've got no money anyway. Because I didn't write that book about the low-carb diet. I've got no money. No one bought the book about the healthy diet. All right. So, often in the hospital, we'll put people on a soft diet and not even tell them why. We'll just make the decision and walk out and not explain it. So it is great to involve a patient in their care. And look, that's going to set them up for home in being able to manage this condition at home. Because I don't know what your facility is like, but we might have them from 1 day to 1 week, and then they're at home the other 51 weeks of the year. So that we really need to set them up to manage this condition at home. Okay. Convenient meals. This is something that a patient may need a transition towards contemplating, going from pre-contemplation to contemplation to action. A patient may love cooking. They may have been independent. They may not be accepting of the idea of Meals on Wheels. That's for old people. That's for broken people. So, but there are other options depending upon where you live. There's Home Chef and delightful dinners, and a lot of them are really competitive these days. That, for $7 odd on average, you get a meal that someone has done the shopping, the cooking, the cleaning, and you get it delivered and you heat and eat. And that is the business for someone with a progressive respiratory disease. That is the business. And it's not a life sentence, right? You could do it 3 days of the week. You could do it just your nighttime meals. You could do it just your lunchtime meals. Your other meals, you could make something if you really like to. Anyone feeling sleepy? Any questions? Okay. Should I ask some questions? If I ask you a question, will you stay awake?
No, I need questions.
Okay. So this is all common sense, right? Nutrition, snacks and supplements. So one of the things that I'm sure you would have heard is that one of the automatic things that we recommend is small meals more often, and that's basically snacks in between meals. Have a small meal. If you have the luxury in your facility of choosing smaller portions, a lot of people with COPD, little old ladies, will be overwhelmed by the sight of a large meal, right? You've heard it. So choose small meals if you get that option. Encourage them, look, don't be worried about what you waste. Your health is more important. Eat what you can and then have a snack in between meals. Supplements, sometimes, if they're really acute and they're struggling to breathe, supplements is just the easiest way to preserve their energy and protein intake, to preserve their lean tissue, to preserve their muscle mass and their function, to get them through that acute period. Okay, and apart from essential nutrients, there's non-nutrients. Do we have any water? Is there any?
Oh, it was. Yeah, it is.
I just thought there might be a... Oh, here they are. Ah, just behind you, Paul. Thanks, guys. So there's essential nutrients and there's non-essential nutrients. I kind of am tempted to... Can we stop the video for this statement? I'm kind of tempted to move fibre into the essential nutrient bracket. So essential nutrients are nutrients that your body... Now I'm going to justify my rogue statement now. Essential nutrients are nutrients that you will develop a deficiency disease if you do not have enough of in your diet, right? So vitamin C, you'll get scurvy. Anemia, inadequate iron intake, you'll get anemia. So inadequate fibre intake, you get constipation, yeah. So you'll get diverticulosis and ultimately diverticulitis. So that's a problem. So you can almost consider it an essential nutrient, and I think it's pretty important for your health and your well-being. So a prebiotic and a probiotic, fibre and probiotics. If a patient's getting hammered with antibiotics and they get antibiotic-associated diarrhea, we rule out infection and bacteria, and then a probiotic is something to worth consider. Okay. One of the things that you would automatically think about when a patient presents to hospital with unintentional weight loss, with weight loss that's unexplained, you'd be thinking about cancer. And the reason is that cancer, there's a cut that is associated with cancer where there's just a muscle wasting. The tumour can affect the body metabolism and protein turnover, and the classic cancer patient toward the end of the disease will just be wasted. Not everybody, but that is and can happen.
So is the unintentional weight loss usually just at the end of when cancer is quite progressive, or is it an early symptom?
Yeah, look, it's one of the things that I think has led to a diagnosis. So you can have obese people present to hospital and 30 kilos, and so I probably should add in another thought here, is that I've had patients say to me, I've been eating the same as I always eat and I've lost 30 kilo in 3 months. So then they'll start investigating, because there's not many causes for that. Cancer is one.
Because we get told to look for physios, getting on patient by patient comes in with pain, or I've also lost weight. I just was wondering if it only happens kind of when the cancer's quite progressed, or if it's something that do happen in the same.
Yeah, look, it can be early.
Yeah.
And I'm thinking that probably, I'm stereotyping, but I'm thinking about men, because they won't go with the early symptoms. They won't go to present to the GP with the early symptoms. So there's a possible explanation but also it can be an early symptom, because a later symptom would be nausea and loss of appetite and all of the other nutrition impact symptoms or barriers to good nutrition associated with cancer. So there's lots of barriers to good nutrition with cancer, and cachexia and malnutrition is common. There's a lot of myths surrounding nutrition with cancer. There's a lot of misinformation about nutrition in the community. There's a lot of information out there and a lot of misinformation. And who's heard some myths about cancer and nutrition? Yeah, what are they?
Avoiding basically anything that's to do with the Western world and go holistic, which in itself seems to be redefined by a lot of other
Yeah, great.
alternative areas.
Yeah, great. Any others? Juice diet. Okay, now we've got. Yeah, great.
Yeah, the raw foods.
So sorry?
The raw foods.
Raw food. Yeah, just eat raw food and cure cancer. Sugar. Okay, that's a really common one. Yeah, that's a good one.
Red meat.
No, but there's a myth out there that sugar feeds the cancer. And so if you avoid sugar, you can starve the cancer. Now, what did I say earlier on about not having carbs, sugar? Who's going to starve? The tumour or the organism, being us? So the tumour doesn't starve. So the tumour alters, a tumour is a rogue. A tumour is a rogue rebellious cell that does not function for the benefit of the organism, us. So the tumour will be greedy and alter the metabolism and take all of the nutrition for itself and grow out of proportion to the surrounding cells. That's one of the characteristics of a tumour. So even if you starve yourself, completely don't eat, the tumour will eat anything that's left.
I understand this. Is it true that if you have a lot of red meat, you're at increased risk of bowel cancer? You can't eat it. I have looked at studies.
Yeah, my father-in-law's been told by one of the doctors here not to eat red meat.
Yeah, look, it's a broad question, which is why I took a breath. And it's a changing, the evidence is changing. So from when I studied to now, the evidence is increasing that high intake of meat in your diet can increase your risk of bowel cancer, or it is associated with increased rates of bowel cancer. On the other hand, we know that lots of people eat meat their whole life and don't get bowel cancer. So association doesn't prove causation. And we know that meat is a nutritious food. So it's really, makes a unique contribution in our diet to iron. So it can be difficult to get enough iron in your diet without red meat. The problem is, and so if you went to a health professional, they'd probably tell you that 2 100-gram serves, and they've probably changed the grams since I went to uni, but 2 approximately 100-gram serves of red meat in your diet a week is adequate, and the rest you can have some chicken and some fish and some meals without meat. So that would be a healthy diet and probably no risk of bowel cancer, except for those people with where diet is not going to change it. They're going to get bowel cancer anyway because they've got the the genetic familial the polyps all through the bowel, and they're going to get. So I think the biggest risk factor for bowel cancer would be inadequate intake of fruits and vegetables and fibre. So here's my take on it. The solution would be not to never eat red meat. I think that the solution would be to have red meat 2 or 3 times a week and lots more fruit and vegetables in our diet.
No, I'm not a vegetarian. I wasn't saying it because of that.
Sorry, no, look, let me just explain that anatomically my voice is just like this. So I have these mechanics. I can't sing, but I just have a loud voice and a strong voice. So I'm not, angry. Honestly, so some people look at me and I think, did I freak them out? So I get a little bit passionate about nutrition. Yeah, look, the evidence has increased that excess red meat or high intakes of red meat can increase risk of bowel cancer. So that's changed. But I think that a lot's got to do with it, with inadequate fruit and veg intake and fibre.
What's the aim of after sugar?
I'll get to that. Okay, so cutting sugar out of your diet. If you've got cancer and malnutrition, you're just going to starve yourself. And a little bit of sugar is part of a healthy diet. A little bit of sugar. If you have, 2 or 3 teaspoons of sugar a day in a healthy diet with lots of fruit and veg. So, someone with cancer needs nutrition, not dietary restrictions. That's okay. Amygdalin it goes around every now and again. It's what the mythologists call vitamin B17, or which there is no such thing, and it's peach, apricot kernel, yeah. So it goes around every 20 years or so. It goes around, and it's the most foul-tasting thing. You just taste it, and makes you wonder how anybody ever eats it. And basically, the byproduct of amygdalin, vitamin B17, or apricot kernels, is cyanide. So it kills cancer, yeah. So this is what we do when we want to. This is what we do when we want to sell a book. We starve people and give them poison, and that kills the cancer. Unfortunately, the patient dies before the tumour dies. Okay, so look, nutrition is really, really important in cancer, lung cancer, and we need to look at dealing with those barriers to nutrition, whether it's dry mouth, whether it's pain on chewing and swallowing, whether it's nausea, constipation, diarrhea, loss of appetite, muscle wasting. So they need a high protein, high energy diet. I would lift dietary restrictions. So if you've got someone who's 60 and was previously on a healthy heart diet, and now they've got lung cancer and they're developing cachexia and malnutrition, I'd be thinking about lifting the dietary restrictions. They need some fat. They need some fat, they need some salt to make the food taste good. They need fat and grease. I'm joking. Oh, okay. Any questions? Does anybody need to stand up, go to the toilet, have a drink? We're really in trouble because I got the quick presentation out of the way so I could really get passionate. I didn't come prepared. Ed from the out there caught me. I normally like to come in and get set up, so I apologise about that. That's disgusting. Which one do I look like? The physiotherapist here thinks that's me. Can you see that? This is what we do here. You've seen the dive. Is this a pointer? Here it is. That's what we do. We'll probably do a little bit of all of that. Okay. Nutrition is really important in cystic fibrosis and really, really important in growth. How many people have cared for someone with CF? Yeah? Yeah? Okay, awesome. I can see some familiar faces around here, right? No? Okay, there must be a limited combination of noses and eyes in the gene pool. People say to me, you know, that they know me or they... Anyway, we've probably talked about all this, haven't we? So once again, some revision. Nutrition is really important for everything. Nutrition will make you, good nutrition will make you feel fantastic. And it's especially important in cystic fibrosis. So, just a little bit of the background here. If you lived with CF in the 40s, you lived to if you were really lucky, you lived to about 2 years of age. Then they discovered what CF was. And in the 70s, your median life expectancy, so you know the midpoint was 16 years, I probably need to update this presentation because I went to a presentation the other night and someone said 41 years, but I actually think that the median life expectancy is about 37 years. But if you're born today, you can be expected to live beyond your 40s. So what we see there is a trend where it's increasing. It used to be a childhood disease and now is a life-limiting disease. So there are actually now, in many countries, in many centres, more people with CF who are adults over the age of 18 than under the age, so children. So, you know, that's good. And part of the reason is nutrition. So back in the 80s, because of people with CF having pancreatic involvement in their pancreas being blocked and the enzymes not getting into the gut and having malabsorption, they were all put on a low-fat diet. So if you know about anatomy, fat is all absorbed in the small intestine. Fat normally doesn't end up in the bowel, in the large colon. So that's a problem when you get fat in your bowel, because you know you can be incontinent. I mean, there's a medication called Orlistat, and if you give that to patients for weight loss so that they malabsorb fat, it's best not to go out in public. Honestly, it's best to stay home. So I know dietitians that have had them. No.
There was a diet paper that was based on it. One of those ones.
Oh, yeah, Xenical.
Xenical, it's
Yeah.
and you just have to sell a little day. Is it good going now?
Yeah. So this is basically what in the 1980s people with CF had steatorrhea, and any fat that they ate went straight through them. And you know, it's a problem if you're at school. It's a problem anywhere. It's a problem, you know, in the car. Can you imagine, right? So, they were on a low-fat diet, but they also had malnutrition. So they tried to put them on a high-calorie, low-fat diet, which is an oxymoron. So you actually really, really, really difficult to get a high-calorie, low-fat diet. Horses are on a low-calorie, high-fat diet. How does a horse eat? Oh, excellent. All right. All day. All day. So if you want to gain weight by eating salad, you will have to eat all day and all night. So the people in Canada were given enzymes, oral enzymes, and a high-fat diet. So trying a new therapy to match the enzymes with fat in the diet. And they did a study. And after so many years, they stopped the study because the patients were taller, they grew normally, they were heavier, and they had an improved life expectancy. And I think the median life expectancy was 7 or 8 years longer. I've got there 21 to 30. That may even be a typo. I apologise about that. But a very, very significant life expectancy. So if you are currently, the median life expectancy is in your 20s, and someone offered you an extra 8 years of life for a high-fat diet, it's a good deal, right? And the diet at that time was unrestricted in fat. So if you've got malnutrition and you've got low body weight, underweight, and losing weight, and at risk of continuing to lose weight, you are not afraid of any type of fat. You shouldn't be afraid of any type of fat. You shouldn't be afraid of saturated fat. You shouldn't be afraid of any type of fat, because your actual cholesterol levels will be below the normal range. So we have a normal range for hemoglobin, we have a normal range for albumin, we have a normal range for cholesterol, and there's a lower and an upper limit, right? So a lot of people with malnutrition, their cholesterol levels will be below the normal range. It's just that it's not common in our society because we're all at risk of eating too much. Some of you are nodding. I'd be nodding because I can eat too much. I can gain weight. So it's in our society, but people with CF are at risk of malnutrition. Let's move through this quickly. This is adults. See, we're catching up. Adults. And this is America back in, 2012. So it used to be a childhood disease. And now it's half and half about. This is children in America, so under the age of 18, 6 to 19 actually. 2012 this is done. This is their ratio of their height to weight, BMI percentile. And you can see that as the BMI, as their body weight goes up, and their BMI percentile, so it's taking into account height and weight, their lung function improves. Boys and girls. I like the picture with adults better, just because it's like, I work with adults. But you can see that, so these are populations, snapshots in time. The population with a BMI of 17 has a really poor lung function. This is almost end of life stuff. This is stuff where you're starting to get depressed because you're dragging around an oxygen bottle. You can't work anymore 5 days a week. Your medication treatment is a burden. You're coughing, and so on. So the population with a BMI of 22 and 23 has a much better lung function, almost not limited in their activities of daily living. And that once you get to this ideal body weight range, so, this is population, so there are outliers within this, right? But around about a healthy BMI, 21 to 23, it plateaus off, and there's no real benefit from being excessively overweight.
So are you saying that by increasing your body mass, your lung function improves, or is that as your lung function decreases, you lose body weight as well? Not sure. Just.
So there's snapshots in time. So all of the, so a lot more people with CF in North America. It's a lot of numbers compared to what we've got. So when they synthesize the data, there's this R=1 relationship between lung function, which is life expectancy. Lung function, as FEV1 predicted, is life expectancy. As it goes down, you're approaching the end. And BMI. And these people have grown. So as their BMI goes up, it goes up by their weight going up. So there's a direct relationship that the people with a higher BMI have a higher lung function. So it is an association, but a pretty strong and convincing association. It doesn't necessarily mean that increasing your weight will increase your lung function, but my thoughts are that when we're thinking about malnutrition, we're thinking about inadequate food intake and therefore inadequate nutrient intake of everything. Iron, magnesium, calcium, energy, protein, vitamin C. Does that make sense? So does that answer your question? Okay, you guys know all about this? You've had this? So it affects the gut, pancreas. Energy needs are increased. 120 to 150% of normal, up to double. These are population recommendations, I just need to say. So they're, there's increased protein turnover, and a lot of this is associated with malabsorption. So about 8 to 9 out of 10 patients with CF will have pancreatic insufficiency. So they don't, their pancreas is not functioning, producing enzymes for whatever reason, and they need to take enzymes with their food. And they're often also underweight. And because of malabsorption of fat, there's malabsorption of fat-soluble vitamins. The multivitamin that we recommend is Vitadec. It's also got some water-soluble vitamins in it, but the important ones are the A, D, E, and K, which are fat-soluble vitamins, because they will malabsorb fat-soluble vitamins from food, and those vitamins are really important for health. Increased salt losses, so salt needs to be replaced in the diet, because salt is sodium chloride is an essential nutrient. You cannot synthesize it in your body to meet daily requirements. So the only problem with us is that we're all eating too much if we're not having a healthy diet. Our nutrition needs are increased. Okay, so talking about fat now, because we'll probably come across this question, and this is my take on it. I've been saying this for several years now, before anybody else was talking about it. Not really, I'm just joking. Okay, so the high-fat diet is unrestricted in fat types, but I had patients come to me and disturbingly were just eating a lot of junk food. Oh, what happens? Ah. Okay. Well, that's just in time for us to finish, right? Okay, so look, if you need to eat, during an admission, during an exacerbation of CF, during periods where you get really sick, where you have an infection and inflammation, and that increased protein turnover, increased energy goes up, goes from 150% to 200% of normal. So you, without CF, you need 100% of your energy requirements. Does that make sense? You, with CF, need 150% of your energy requirements, up to double at times. At the same time, you're sick, you lose your appetite, and your intake is decreased. So how do you get twice as much food in a smaller volume? It's by fat. Of course, the horse has to eat all day. And people on a high-fat diet, it's easy to overeat. It's easy to overeat with a high-fat diet. However, there are healthy fats, good fats and bad fats. And if someone with malnutrition, as I said before, is underweight and losing weight and can't eat enough, it could be that their cholesterol levels are low, so we're not even worried about that. So any fat that they ate would be good. If they liked eating takeaway food or unhealthy food, they could go for it. They can put butter on their bread. But on the other side of the argument, olive oil, polyunsaturated fatty oils, fish, is also 37 kilojoules per gram. So if we're comparing apples with apples, a gram of healthy fats is the same energy as a gram of unhealthy fats. So people with CF can have, in my opinion, a healthy high-fat diet. Just that we wouldn't really limit unhealthy fats in someone who is underweight anyway. And if they like eating that, I'm not going to argue with them over that. Does that make sense? Any questions there? I kind of answered the question before you asked it. I get asked that question every time. So this is the healthy CF diet. So the other one was the Australian Guide to Healthy Eating, the old one. I haven't updated it. They're all the same. It's a plate with healthy food on it, and those healthy foods you should eat every day. And on the Australian Guide to Healthy Eating, these foods you should eat sometimes, but in the CF diet, this is my take on it. We put the snacks in and eat them, enjoy them as part of a healthy diet if you're underweight. If you've got CF and you're overweight and you don't even need enzymes, you probably shouldn't have those things every day. I'm happy for questions. About 9 out of 10 people with CF need enzymes. There are different strengths. And there are different brands. So there's the main brand in Australia is Creon, but there's also Pansy Trap. Did Ed tell you about that? Pansy Trap, 25,000. So match the enzymes with fat in the food. And different people with CF for different anatomical reasons will all require a different amount of enzymes with the food that they eat. And you start off with a low dose and increase the dose until you have controlled the symptoms, which would be steatorrhea and gastrointestinal upset and weight loss. Enzymes also contain, the tablets also contain the enzymes for protein and starch. And they are needed to digest and absorb those foods. It's just that those foods are not symptomatic, mostly. Protein malabsorption is asymptomatic. You don't have any clinical symptoms, but you have clinical symptoms of fat malabsorption. So we match the enzymes to the fat in the diet, and the protein and the carbohydrate in the diet usually follows the absorption of the fat. So it's usually adequate. Any questions? So basically we recommend taking them with food as you start to eat, but they last about half an hour. So people who eat slowly or eat food after half an hour, additional food will need to take more enzymes. So this is a picture of enzymes. They go round and around in the stomach, the acid dissolves the coating, and they go into the small intestine where they optimally work in that's where they're absorbed. And that's where the nutrients are absorbed, and this is where they operate. They operate on the semi-digested soupy chyme to break up the chains of triglycerides and starch and protein into amino acids and fatty acids and glucose or to get absorbed, or disaccharides. Really important that people with CF grow well. As they're growing, their lungs are growing, that will put them in good stead for later life. My golden rule is that food is best. I would actually like to see people be able to eat enough food without needing to have a supplement, unless it's, medically needed. So try to adjust their food choices and the menu to suit their needs. How do we get a high-fat diet? So the cooking methods, adding fat in cooking, adding fat at the table is a bit of a barrier to getting a high-fat diet in a family. Is how does someone who's, the parents who are at risk of becoming overweight cater for the kids who are at risk of becoming underweight? So one way is to add salt and fat at the table. So adding mayonnaise and adding dressings with olive oil and adding butter to the bread, dips and pestos, that's a good idea. Ice cream and adding cheese to food. Snacks is a good way so the kids and the people with CF can have high fat, high salt snacks. I still recommend eating fruit. So supplements are good. We give them the vitamins, iron if they need it, salt if they need it. So salt needs will change with salt losses. One of the things that probably needs to change is giving CF patients salt supplements every day on the days that they don't need it. Ideally, and we don't live in an ideal world, but ideally they would be taking the extra salt on the day that they need it. So when they're sweating is when they should be having the extra salt. So if they're in an air-conditioned room or in winter and they're not sweating a lot, they could probably get away with having salt in the food cooking and salt added to their food without needing to take a salt tablet that's got lots and lots of sodium in it. Why take more tablets than you need? Why take more of any drug than you need? Yeah? Omega-3, fatty acid. Emerging therapies. Okay. Some people with CF may need invasive nutrition. There are different options. There can be gastrostomy or overnight nasogastric tube. Not many adults that I've met opt for gastrostomies. Some of them will even put down a nasogastric tube every night. I think, why not just drink the supplement? Because even if we put a gastrostomy in or a nasogastric tube, you might be having 3 or 4 supplements a day. If you could find a palatable one, you could drink 3 or 4 a day. Why need a gastrostomy? That's my take on it. But some people do, and especially when they're growing. Kids sometimes, and really get the benefit from it. It can really help them during growth. So here's an example of calorie or kilojoule increase adding fat to food. So it's pretty obvious, isn't it? Like boiled potato, mashed potato, chicken wing baked with the skin on, show, cheddar cheese. Cheese is a good source of fat, isn't it? Thank you very much.
Thank you.